ready?
Just after the Western Theater.
Hello, everyone. Welcome to the December Scholar Share. Today we have two amazing speakers and an amazing moderator. It is my pleasure to welcome everybody. Please grab some food, make yourselves comfortable, and we're going to start. So as today's moderator, we have Dr. Kwok. Dr. Kwok is a full-time administrative staff and adjunct faculty here at Drexel University. He's currently the Associate Director of the Graduate College and manages around 6,000 graduate students. He works together with faculty, professional staff, students, administrators across the university in order to help us graduate, put in forms, change classes, things like that. Dr. Kwok is committed to a range of initiatives aimed to enrich many academic, research, and experiential learning opportunities for all graduate students. With that said, please let's welcome Dr. Kwok.
Thank you for the introduction, Guillermo. Welcome to Scholar Share. Don't be too sad, this is our last Scholar Share for this year, but we have many more wonderful presentations next year. So thank you so much for having me as the moderator today. Over the years, I have the privilege to listen to many wonderful interdisciplinary conversations from different academic disciplines. And today we get to hear two more presentations highlighting real issues that are affecting the human race. And the first research topic is actually on eating disorder. Eating disorder is actually a very serious issue that affects, a lot of people. And according to the nationaleatingdisorder.org website, 20 million females and 10 million males have or had an eating disorder at one point in their life. And so we have Kelsey Clark, who's a third-year PhD student from the Department of Clinical Psychology under the supervision of Dr. Adrian Gerazio. And Kelsey will give a brief presentation on helping people with an eating disorder. And so without further ado, it is my pleasure to introduce Kelsey Clark.
Hi, everyone. So today I'll be speaking about my experiences with research. And my topic is, like Dr. Kwok was saying, is about helping people with eating disorders learning how to walk the walk and acquire skills and use the skills that we learn in therapy. To start, eating disorders can look really different from one person to another, but essentially what these disorders are is they're really serious as mental illnesses that are characterized by having behaviors and thoughts that are related to shape and weight and eating that really get in the way and are distressing for individuals who experience these disorders. The current estimates are that 1 to 3 individuals out of 100 will experience an eating disorder in their lifetime. So these affect a lot of people, and they're associated with extreme distress, impairment psychologically, socially, with work and daily functioning. And many individuals with eating disorders have another mental illness as well. And because of the physical nature of the disorder, they're associated with a lot of medical complications, as well as a high mortality rate and a really high suicide rate. So these are really serious disorders that we need to be able to treat well. And we do have good treatments for these disorders. We have different kinds of talk therapies, some kinds of medications that work. Unfortunately, even with our current best treatments, as many as 60% of patients that are treated, do not fully recover from their eating disorder at the end of treatment, or they later have, remission and have a relapse of their eating disorder. And so we have a need for better treating these. And I think a lot of people who are familiar with this cartoon, I think this is a good way of kind of summing up what I think is a key area for improving treatment for eating disorders, and that's the idea of distress tolerance and emotion regulation. Those are kind of big words, but essentially what this means is a lot of us, we experience, stress and negative emotions in our day-to-day life. And a lot of us were able to emotionally regulate. If we're the dog in the famous cartoon, then we're able to maybe, dampen those fires with a fire extinguisher or something, or we're able to, just tolerate, okay, this is fine, I can get through this, this negative experience. However, for people with eating disorders, what research has shown is that the reaction, instead of being like this, is more like this. This is not fine. And so that's when we get then the kind of eating disorder, behaviors in an attempt to try to regulate those emotions. So just to highlight what this looks like, is essentially there are deficits related to people with eating disorders being avoidant or intolerant of negative emotions. And so we need then skills to help regulate or tolerate those emotions. So just to explain further what this looks like. So say, in a person's daily life, some kind of stressor comes up. So maybe they have a bad day at work or school, they get into a fight with a loved one. That results in, some kind of negative emotional response, maybe fear or anger or sadness. And what we see with eating disorders is a lot of times then there's kind of this reaction to that emotion, ooh, I don't like that, that's uncomfortable, I want to make that experience go away. I shouldn't be having this reaction. So then we get, some kind of avoidance or intolerance response. And so for eating disorders, that's where we see things like binge eating behavior or, purging or compensatory kind of behavior, things designed to influence one's shape or weight in an effort to, feel better and lessen that distress. And the thing is that this works to some extent. There's this relief, in the moment, it does kind of bring down that negative emotional response. However, what we then see is that later on, then we're getting, there's impairments in daily life, or there are, we're getting a lot of the problems that come with having an eating disorder, like I was describing earlier. So then it's kind of relief, but it's dampened by later guilt or shame or other kinds of problems. And so what this does, because the person never gets a chance to learn, oh, I actually can, ride out this negative emotion, or I can get through this stressful situation without these eating disorder behaviors, then it just keeps the cycle going. So we never get a chance to, break this and start a different pattern. So that's where my research comes in. I'm interested in improving treatments for eating disorders and better understanding these emotional processes that maintain eating disorders, particularly by treatments targeting these emotional responses. So what this looks like, this section of the sort of cycle, things like stressful life events, negative emotions, we can't control that. That's part of the human experience. But the part that we can control is maybe how people with eating disorders respond. So maybe understanding and accepting having a negative emotion, that's part of life. That's an okay reaction for me to have. And then learning how to have skills behaviorally to respond when those life events come up. So this is about learning skills that replace eating disorder behavior, learning that in therapy, and then translating it outside the therapy office. It's one thing to sort of talk about it once a week for an hour with your therapist. It's another thing to do it in the wildness of daily life. And just to kind of better explain, what are these kind of skills that I'm talking about? These are a number of different examples. I'll highlight first one that we call mood modulation. This is a kind of emotion regulation skill. It's a way of changing your emotional response. This could be doing things like maybe doing some kind of hobby or activity to calm yourself down, getting social support, like calling a friend, maybe getting some rest, doing mindfulness meditation, things like that. And then an example of a distress tolerance skill, this is the idea of observing and watching the rise and fall of your negative emotions or of your urges. Because many people, what we've seen in research is that people with eating disorders, they often have the experience of oh, I have this urge maybe to have a binge eating episode. And that feels like that urge is just never going to go away. It's going to keep rising and rising. What we know is that won't happen. Urges do rise and fall. Like other emotions over time, and so learning how to sort of surf those urges out and notice them rising and falling like a wave is a helpful skill. And so there are two kinds of treatments that I'm interested in that get at these different kinds of emotion-related skills. First is a type of treatment called acceptance-based treatments, and this is really focused on the old sort of adage of like learning how to change the things that you can and accept the things that you can't. And then the other type of therapy that I'm interested in is exposure therapy. So in a nutshell, what this looks like is the idea of very intentionally approaching the things that people are inclined to avoid in order to have the learning experience of like, oh, I can face my fears and not have that feared outcome occur, like I'm afraid of. And so these kinds of treatments, acceptance-based treatments and exposure therapy, this gets at like changing how people respond to the negative emotions and then changing how like their reactions to it and then their behavioral response as well. So what this does is instead of having this like, oh no, I shouldn't be feeling this way, I want to make it go away, we have more of an acceptance kind of reaction and then a behavioral response of like maybe approaching a feared situation using those skills that they can learn in treatment. So then we have a different kind of reaction. Maybe there's some discomfort in the moment because facing your fears is very scary. But then over time, people have that learning experience of like, oh, the thing I was afraid of didn't happen. I can get through this. I can survive. And then we have a different version of like that cycle going on. And I'll just briefly note, so one of the main projects I'm currently working on is finishing up my thesis project, which I'm doing video coding of therapy sessions of patients with bulimia nervosa. So we're watching the videos and observing what happens when they go through an exposure therapy, trying to see how patients respond, like, the treatment sounds kind of scary. Like as a therapist, it really kind of stinks sometimes, the idea of like, okay, I'm going to intentionally make this person potentially really upset, having them approach a food that they're afraid of binge eating on or something, for example. But what we're seeing so far is that a lot of patients, this is one patient's reaction, is that it's an uncomfortable experience, of course, to face your fears, but it's also powerful and it can be a good learning experience of like, oh, I can practice these skills that I'm learning to face the things I'm afraid of. And I think that's been an interesting experience for me in my graduate career thus far is, learning how to, like I'm doing like clinical research, so I'm doing these research projects that are about therapy with eating disorder patients, and then I'm also learning, how to be a therapist, be a clinician myself, and so kind of seeing the, the connections of like, I learn things in my research that I then take into clinical work, and I learn things in clinical work that I then take into my research. So there's a really interesting kind of dialogue there. And yeah, I have a number of different experiences across Drexel with eating disorder patients and with other kinds of mental illnesses as well. And I think another thing that I've become interested in, and I think my research interests have really have started a lot of dialogue about this, is this, what we call the research practice gap. So this is the idea that we spend all this time and effort, all the stuff I was just talking about, we're trying to improve these treatments for eating disorders, but then what we see is that there is a big gap. Like what a lot of clinicians out there in the real world are doing is oftentimes very different. Like there are many clinicians who treat eating disorders who aren't doing this acceptance-based kind of stuff, who aren't doing exposure therapy. So how do we kind of bridge that gap so that we can get the research out to the real world, and so that in research we can learn from people out there in real world practice? So I'm very interested in advocacy efforts to kind of further increase that dialogue, and so we can get more integration with research and practice. So in sum, this is all about, the title of the presentation was about getting eating disorder patients to walk the walk. It's learn these skills in therapy and then translate them to daily life. And I also think that for me as, a graduate student, I'm learning it in my career about walking the walk of integrating research, clinical work, and advocacy so that we can continue, trying to help patients with these very serious mental illnesses. And so that's it. So thank you very much for your time.
Thank you so much for the presentation. At this time, we'll accept one or two questions from the audience, but I will start first. So earlier in the presentation, you have mentioned a lot of important statistics, right? You said 1 out of 3 people have an eating disorder. So as a collective group, how can we help to raise more awareness about this issue? What can we do to help?
That's a really great question. And to clarify this statistic, it's between 1 and 3, like different studies vary, 1 and 3 out of 100. So it is still serious, but not quite as, at least current estimates. So yeah, I mean, I think one of the biggest things is there's a lot of, I think, yeah, I don't know, it's like a trite answer, I think, but like awareness is a big thing, I think, with eating disorders. Like, I think that because there are a lot of stereotypes about like what eating disorders look like, who has these disorders, there's a lot of, really outdated like messaging around like, oh, it's just, young, affluent white females who have these disorders, like it's just a choice, it's not very serious. I think those kind of messages are still very much out there in society, and that really impacts treatment for these disorders, like treatment seeking, as well as research. Like currently, I think there was a recent study that was saying that like in like U.S. federal funding for eating disorders, it's like less than $1 research dollar per affected individual is like spent on eating disorders treatment research, which is really staggering considering how serious this is. So I don't know, I might encourage folks to, just pay attention, because there are like advocacy like messages that are out there. The National Eating Disorders Association, I know you were referencing their website, they have an annual awareness week, and that's something we need to be helpful in, like, because I think we perceive these disorders as being much more rare and much less serious than they actually are. So maybe paying attention, and next time you see messaging around like, who has an eating disorder, maybe questioning if that's actually the case. That might be one place to start.
How do you have a conversation if you were to notice that someone has an eating disorder and they're not getting help? How do you have that conversation with the person that may be very near to you? How do you start that conversation?
Yeah, that's a really good question, because it is a tricky thing, and I think the instinct like to be concerned about someone is right, because a lot of times these illnesses, they do sort of go under the radar because there's a lot of like stigma and shame. So I think that if you are concerned about a friend, like maybe how they're or a loved one, like maybe how their relationship with food or eating or weight, some of the main things I would say would be, trying to find the right like time and place to have their conversation, doing a little bit of research. Organizations like the National Eating Disorders Association actually have pages on their website that have tips for like how to have this conversation in a way that's going to be helpful for people and isn't going to come across as like, further, shaming or guilt-inducing. But I think the biggest mistake would be to say nothing at all. I think that saying something and like having that conversation, even if it's not perfect, would be the best thing I would recommend. Mm-hmm. Yes.
In terms of, you had mentioned the video coding.
Yeah.
So when you're obviously in a clinical setting, you have like a wide range of data you're collecting. So how do you decide when you're going through this, what is important and extractable data that you can work?
That's a really good question. Yeah, we did a lot of, like, developing the coding system for this was really interesting, and I think it's an area that I want to see more development in psychology, like kind of having this like mixed methods of like qualitative and quantitative data. I think that in designing the coding system, we were really coming at it with the goals of looking at, okay, is this treatment, like just describing what this even looks like, because there are a lot of people who don't even have a sense of like what exposure therapy for eating disorders would look like, so characterizing it, looking at feasibility, like is it possible to implement this treatment like how we would intend, acceptability, so like how did the patients and the clinicians respond to the treatment, and then any kind of evidence of like efficacy, so the treatment working like we intend. So with those kind of aims in mind, we were looking at verbally, like what patients and clinicians would say and what they would do in the session, so like things that you can observe directly in that way. And trying to do our best. It's definitely tricky, like trying to code emotional responses, because maybe what someone is demonstrating on their face might be, or like with their body might be different from what they're experiencing internally. But those are all things that we were paying attention to.
Any more questions? Well, let's thank Kelsey again for a wonderful presentation. Well, next up, we have another speaker from the Department of Clinical Psychology. We have Alicia Desai, who's currently working under the supervision of Dr. Kirk Halbram, and her research focuses on the treatment of substance abuse which affects our brain activity and also our behavior. And some of the chemical substances are alcohol, nicotine, and marijuana. And so mental health and substance use disorders affect all walks of life and all age groups as well. So without further ado, it is my pleasure to introduce Alicia to the stage.
I'm very technologically illiterate, so let's see. Okay. Perfect.
Is it this one?
Yes, awesome, thank you. Okay, hi everyone. Thanks for the introduction. I also just quickly want to mention my other mentor, Dr. DiMatteo, in addition to Dr. Halpern. But today I'll be talking about hold on. Sorry, perfect, okay. Today I'll be talking about what I focus on as a clinical psychology student here, which is the treatment and study of substance use disorders, and specifically I'm going to talk about more of the research side of things today. So for some background information, in 2018, over 50 million Americans aged 12 and older reported using drugs during the past year. And this includes things like marijuana, which is currently legalized or decriminalized in parts of the country, and the misuse of prescription medication as well. So things like Xanax, prescription opioids. And of those over 53 million, about 20 million reported actually having a substance use disorder, the vast majority of which is accounted for by alcohol dependence, with about 8 million reporting drug dependence as well. And I'll get into in a moment what kind of differentiates recreational use from an actual substance use disorder. But as I'm sure most people have heard of, a lot of this has been driven by the opioid epidemic in recent years. So opioids are the leading cause of overdose and of overdose deaths in the United States currently. So when we talk about what an actual substance use disorder is, no need to read all of that. I kind of wish I hadn't put it up there. Should have gotten Kelsey's help with my slides. Hers were awesome. But this is just what is pulled out of the DSM-5, which is our manual for determining mental health disorders in psychology and psychiatry. So it's broken up by the type of substance, but this criteria is more or less the same across all SUDs. So in the past 12-month period, these individuals have unsuccessful efforts to control or stop their substance use, and a lot of their time is spent trying to obtain the drugs, and this often occurs at the expense of things like employment, education, their family, social lives. There's also high levels of cravings or urges, which is the most common reason that individuals report relapsing after periods of sobriety. Increased tolerance, so needing more and more of the substance to get the same effect. And also withdrawal, which can be either emotional or physiological, but these are the symptoms that individuals have when they try to stop using. So when we talk about SUDs in the United States, this is inherently an interdisciplinary matter. I'm going to briefly touch upon each of these three domains and then kind of focus more specifically. But when we look to the medical system, what we're seeing a greater focus on and emphasis on is the disease model of addiction. So this is viewing drug and alcohol dependence as a chronic relapsing disorder, similar to something like diabetes that has a genetic predisposition to it as well. Also, what we know about the gold standard or first line of treatment for things like alcohol use disorder and opioid use disorder is medication-assisted treatment. So people may have seen kind of recent advertisements for things like Vivitrol, Suboxone, the more commonly known methadone. At my clinical placement at the Philadelphia VA, currently I work out of the methadone clinic, so that's one of the ways that psychologists can be involved in the medical system to treat individuals with substance use disorder. About half of the states in the United States have some sort of mandated reporting laws, so physicians and other clinicians have to report to local law enforcement if certain populations are either suspected or confirmed using. One of the most common ways that this comes up is use during pregnancy. And lastly, we see a significantly higher amount of certain chronic illnesses amongst this population. So for example, amongst alcohol abusers, we see higher rates of liver damage. Individuals who use drugs intravenously are more likely to have HIV or hepatitis C. And so this all involves a lot of kind of involvement of the medical system as well. So looking next to the legal system, as I'm sure everyone is aware, certain substances are legal, such as alcohol and tobacco. recently changing marijuana as well. And then the remainder of substances are illicit, so this inherently involves the possibility for arrest and legal involvement. There have also been the introduction of certain laws to address drug use specifically, so things like possession of drug paraphernalia, intentions to distribute, or similar laws like that. And lastly, we also see a number of crimes being committed to support drug use, so things to obtain money, say, to be able to buy alcohol or drugs. And lastly, we have the government's involvement. So especially in recent years, we've seen increased efforts to propose new legislation or policy that can address substance use. We see under the current administration the opioid task force, so different efforts like that. Additionally, funding for medical or mental health treatment for substance use disorders, which is a pretty significant barrier for us, is also government funded, particularly for the National Institute of Health or mental health. And we've also seen gaining increased attention from all sorts of communities, efforts for criminal justice reform. For the purposes of the rest of this presentation, I'm going to focus on that overlap between substance use disorder and the criminal justice system. And this is where my major area of study comes in, which is forensic psychology. Just to briefly address this, because I often get questions like, so you figure out who murdered someone, or how can you do psychology for a dead person? That's not what forensic psychology is. So essentially, it's just psychology as it applies to the legal system. So anytime there's a question about the emotional or mental health of someone who is justice involved, including law enforcement providers, we are involved as forensic psychologists. I'm happy to answer all sorts of questions about that afterwards as well. So when we talk about substance use disorders in the US criminal justice system, we see that 7 times higher rates of individuals who have substance use disorder that are currently incarcerated as compared to the general public. So these individuals are significantly more likely to be arrested. To kind of corroborate that, a recent study found that between 63 and 83% of arrestees in major cities actually tested positive at the time of arrest for drugs or alcohol. And something that's a common misconception or common myth, there's lots of them when it comes to substance use and justice-involved populations, is that these individuals are kind of the worst of the worst criminals, are committing violent crimes. But actually what we see is that the highest rates are in cases of burglary, drug possession, and robbery. So again, supporting that idea that the vast majority of these individuals are actually just committing crimes to continue to support their habit. So some of you may be wondering why this even matters. We have drug laws in place, certain substances are illicit, so what difference does it make if individuals end up being incarcerated for that? I would argue a tremendous difference. So what we know about how this works is that there's a huge cycle of relapse and recidivism, or reincarceration. Individuals end up incarcerated because of their substance use, and often while they're incarcerated, they don't have access to effective treatment. They go through very, very uncomfortable withdrawal. Their tolerance is significantly lower, so we see very heightened rates of overdose immediately after release from prison. And once they are released, these individuals still don't have the environmental supports that they need, and they also have the added stressors of now having been incarcerated. So it's rare for individuals to not end up relapsing, given all of those stressors. Once they relapse, of course, kind of feeds back into that cycle of reincarceration. So when we think about some of the goals of the criminal justice system, although I think this may be up for debate, certainly one of them is to disincentivize people from committing crimes. And also how it was developed was with the intention of rehabilitation. So if we keep these two things in mind, for me the question is always, why would we expect someone to stop committing crimes if the underlying cause for those crimes is not being addressed? Which speaks to the importance of being able to intervene in this cycle specifically for this population. Additionally, substance use disorder is not an individual problem. It affects communities, families. What we're seeing a lot more of recently is pregnant mothers who are using substances during their pregnancy and then delivering children that are in active drug or alcohol withdrawal. So this really does extend to much larger communities and kind of spheres of society. And lastly, often an important reason, although I would like to think not the most important reason, this has a significant societal and economic burden. It costs a lot of money to be cycling people through the criminal justice system, and also just kind of the lost productivity to society as well. So in terms of the research that I do, a lot of it has implications for defense attorneys and defendants. So how can we get involved at the kind of legal level to direct efforts to successfully defend these individuals? Can we get them diverted to things like drug court that are recovery focused instead of just putting them in jail? Additionally, there's opportunities to identify gaps in knowledge or understanding. We actually see this a lot in clinical psychology. We don't get much training at all about substance use disorders, which I think is a significant issue because it's rare to work in a medical setting and not have patients who have some sort of history of substance abuse. So within our own field, but also identifying amongst judges, parole officers, what those gaps in information are so we can provide those answers. And lastly, ideally, some sort of implications for changing policy or legislation down the line as well. So to quickly touch upon some of my own research, I looked in one study at what the impact of a defendant's substance use disorder was on sentencing outcomes for a non-drug related crime. So this is an important distinction here. There's a lot of case law out there to indicate what a sentence should be, say if it's crack cocaine possession versus methamphetamine. But when judges are faced with cases where they know that the defendant has a substance use disorder but committed, say, a robbery, which as we saw was about 70% of robbery convictions, they're able to weigh the disorder, but it's not actually, there's no like book detailing how they should be sentencing these individuals. So what we found with that was that there were actually no differences in the number of years that the judges recommended for a defendant that had a substance use disorder versus one that didn't. However, we did see differences in their opinions of these defendants. So judges viewed them as less responsible for their crime, likely attributing the crime to the substance use, but also more likely to reoffend. So kind of mirroring that understanding of the cycle of relapse and recidivism. It's actually really interesting that we didn't see differences in sentence length given this, because likelihood of reoffending is pretty much the primary reason that judges weigh in sentencing offenders. And then for my dissertation, I examined the growing issue, as I mentioned a moment ago, of prenatal substance use and children being born with neonatal abstinence syndrome. I think in 2017, 3,300 newborns were delivered with neonatal abstinence syndrome in Pennsylvania alone. So this is becoming a significantly more pressing issue. And we don't really have much in the way of laws out there to direct law enforcement's efforts when they find out about these cases. We have seen in a couple, I think like Tennessee and maybe Alabama more recently, women being charged with things like first-degree murder or reckless endangerment if their child does end up passing away or is seriously harmed by prenatal substance use. But that's kind of in the absence of laws to direct those efforts. So I was looking at how judges and the general public, who serves as both voters and juries in these cases, believes that these women should be kind of handled from a criminal justice perspective. And what we found was that overall judges recommended that she not be prosecuted, but the general public recommended prosecution for prenatal substance use. So what we're seeing here is a split such that judges seem to be more rehabilitative focused, which is very promising and not necessarily consistent with historically what's happened in the US, but the general public continues to take this more punishment-oriented approach. However, what we did see was convergence across both groups, such that they believed mandated treatment was the most appropriate outcome to protect the child in the long run. So this does kind of shed light on that goal for rehabilitation. What I found most interesting and also most concerning about our findings were that for research design purposes, we presented a very, very limited amount of information about this hypothetical defendant, about 3 to 4 sentences, which is much less than juries would have available to them in cases, and the general public believed that was enough information to make their prosecution recommendations and were confident in their recommendations. So what this really tells us is that the general public is making pretty flash judgments about how we should be addressing this issue, and they're not necessarily rehabilitative focused. So I'll end with this. I don't have answers to any of these questions. They're just kind of things to be thinking about and what a lot of the barriers are when we think about substance use-focused forensic psychology research. One of the biggest barriers is that we're talking about trying to change very kind of foundational existing systems in the United States. So trying to make any kind of criminal justice change is very difficult. Similarly for the medical system. Another concern is that there isn't so much interdisciplinary collaboration. A lot of times jurors, certainly I think in law school they don't learn too much about this, and judges aren't very aware of psychology and the scientific research. And I would argue the same, again, within psychology itself and also within medical schools. The other question is how can we disseminate these findings? It's pretty common to publish manuscripts in psychology journals and at our own conferences, but how do we make sure that POs and judges are aware of these findings? And how can we increase funding? We similarly have a very, very large issue in terms of receiving very little amounts of money to support this research, which is obviously a huge barrier. But what I think is ultimately the largest question is how can we build compassion and reduce stigma for these populations? When we talk about either of those in a vacuum, substance-using populations or justice involved, these are probably the two most stigmatized groups in the US. So combine those two and it's a whole other issue. So just some stuff to think about, but that is everything from me. Thanks, guys.
Thank you so much for the educational presentation. So before opening up the floor to the general public, I want to ask a few questions myself, and I just want your opinion, okay?
Sure, yeah.
So now that these substances are, widely available to the general public, what would our future be like? Again, this is just your, I just want your opinion. Should we be concerned? Should we be worried for our future generations?
So when you say the substances are widely available, you mean
Like
just...
marijuana, that's that got legalized, right, in certain states.
Yeah.
Should we be concerned about that?
So this is always very controversial. I'm very harm reduction focused and rehabilitative focused in my own work and personal opinion. We've seen actually in a number of countries, including Portugal, for example, that when they legalized all substances, they actually saw reduced rates of substance use disorders. So similar to kind of what we see with, I guess, alcohol or tobacco, we have seen a decrease in tobacco use overall, despite the fact that it's legalized. A lot of what's going on with opioid overdoses is that it's not clean heroin. I obviously don't recommend or advocate that anyone use opioids, but there's no way to regulate purity of substances or cost or all of these things that are causing things like arrest, going into debt, overdose deaths, this sort of thing. So it's tough, and I don't know that it would necessarily be an answer. I think we will have to see what happens with the marijuana legalization, certainly. But for example, what was happening just before it became legalized was that we saw an emergence of K2, which was synthetic marijuana. So you couldn't test it in urine, people didn't have to worry about things like probation or employment, but it also was essentially made of cleaning solvents. And we saw like 15 and 16-year-olds who were dying of heart attacks, which is something that has never happened with marijuana. So I think, the more we kind of punish these things, the more problematic things are going to fill that space.
Thank you for that. I'm going to ask the same question that I asked Kelsey just earlier. How can we help as a community to reduce substance abuse among these substances?
That's a great question. It's a really complicated question. I really do think a big piece of it is just education and reduce stigma, because so much of it is that people feel really, there's so much shame around it, and there's so many reasons not to disclose, such as, for example, going to jail, having your kids taken away from you. And so social support is, I think, underestimated a ton when we talk about keeping people safe and in recovery. So I think reducing stigma is a huge piece. I also think just making sure that people have the supports in place they need to not turn to things like substance use. So making sure that educational systems are where they need to be, that they have positive role models, that we're not just sending people into jail and assuming that's effective treatment, those sorts of things, yeah.
Thank you for that. So now it's your turn in the audience.
So I have two questions. The first being, in your research, were you able to see like recidivism versus relapse in like carceral versus non-carceral programs? Like treatment versus jail, and then what does that mean for relapse, not necessarily being brought back into the criminal justice system, but like what was more successful? And The second being that, given in the shadow of the opioid epidemic, how many people went from legal prescription opioids who may still have a substance use disorder, but it's a legal and non-stigmatized thing. Like, how do we address that where, you have something that is socially and societally acceptable that can lead to so much harm?
So to answer your first question, I have not done any research into that specifically. It's a good question. Actually, I shouldn't. Before I started here, I was at Bellevue Hospital in New York, where we looked at Vivitrol and Suboxone for opioid use disorder, and we would go actually onto Rikers Island to deliver Vivitrol for some of the guys that ended up being arrested during our work together, and they had significantly better outcomes. Significantly qualitatively. The ends were too small to run any sort of meaningful analysis on that, so that's just kind of anecdotally speaking. The unfortunate thing is that relapse rates are still incredibly high. I think they're about 50% for opioid use disorder. That may have changed. However, it's 90 if they don't have medication. So I think kind of that statistic says it all. Yeah. And to your second question, sorry, you were asking.
So within the context of the opioid epidemic, how many of these substance use disorders started as a legal prescription and can be maintained as a legal prescription, however we're still classified as a use disorder? Like, how do you begin to approach something that had the backing of medical science that we now recognize as a significant problem?
Yeah, so that's a tough one that I have a lot of very personal opinions on. I would actually argue that it wasn't necessarily backed by medical science. It was really pharmaceutical driven. So what we saw actually with that was that when OxyContin came onto the market, doctors were actually told that it had a longer acting formulation than it did. So people were not getting the pain relief that they needed, and then doctors would have lost their licenses more or less to prescribe more than they were allowed to per the FDA. So coming back to this idea of education and maybe regulating more systems than we currently do in the US, I think that if a lot of people had known what they were getting into or were given more pain relief options. I mean, I remember back in high school for myself, you got your wisdom teeth taken out and got a Vicodin prescription for like 50 days, right? So yes, it's legal, but I actually think that does a lot more harm than were we to legalize some of these more innocuous, because to your point, it was a gateway, right? Like the vast majority of those individuals probably would have not chosen to pick up heroin were they not given a pill. So yeah, I don't know what we could do to address that without kind of more closely regulating pharmaceutical companies. Yeah. It's a great question.
So you said that one of the ways to reduce this problem in society is to educate about it, right?
Mm-hmm.
What do you think about the way the substance use and abuse is portrayed in media? Because I saw a TV show on Netflix, like Russian Doll, and it's just like as easy they show how they do cocaine stuff. Like I was very surprised that in America, like I'm not from America, and in my country definitely it would be a really, really bad thing to portray in a positive way substance use. What do you think?
Yeah, that's a great question too. I think that is, I don't know, I would be curious to know if there's been research to look at whether there is an association between like increased media presence and people starting to use. And you're absolutely right that it is glamorized in a lot of settings. And even, I mean, if we look at things like Wolf of Wall Street, there's certain industries in the US where like substance use is kind of just the norm, but it's also high functioning, so nobody really questions it because you still have a roof over your head and income coming in. Yeah, I don't know that I can speak from a research perspective to what impact that actually has, but kind of the opposite, and actually maybe a little bit to your point. I'm not sure if you're familiar with like DARE programs, or if anyone went through that when they were in school, but it's something, does anyone know what that stands for? Drugs Against? It was like an anti-drug thing where the cops would come in and do a presentation for us when we were in elementary school, and they actually found that that had no impact on stopping people from using. And I think a huge piece of it too is that genetic predisposition. I mean, I think lots of people drink, for example, and not everyone develops an alcohol use disorder. And even for opioids, the rates of exposure to actual dependence are very low. Not that many people who actually try them end up dependent, but when they do, it's catastrophic. So maybe part of it too could just be like somehow being able to identify the people that are predisposed and making sure that we're introducing more supports for them on a preventative level. But yeah, I don't know what we can do about the media piece of it so much.
Well, thank you so
Of
much.
course.
I want to thank our two speakers again for coming out today, taking your time out of your busy schedule to talk to us. Sometimes we're so engrossed with our research, it's really good that we came out and, support our peers and also, to see what they're doing as well so that we can collaborate with them. So at this time, I would like to present a certificate to Alicia for her great presentation. So. And then Kelsey Clark as well for your wonderful presentation. So thank you so much. Well, that's all for today. Thank you so much for coming out. And I hope you have the rest of a great day. Thank you.
Take some food.
Do you guys mind if we